AMP2.TV presents You and Your Doctor, teaching you to live a longer and healthier life. Proudly sponsored by All County Healthcare, where people are the heart of our business. All County Healthcare is a Medicare certified agency where one call will service all your home care health needs. For more information, call 954-717-7027 or visit our website, allcountyhealthcare.com. Now, let's get informed to living a longer and healthier life. Here is your host for today's show.
Hello.
Hi.
And welcome. We're on You and Your Doctor radio show, and I am filling in currently for Miss Ballerina Anderson. I'm here with Louise Cleary, physical therapist. How are you?
I'm good. How are you?
Very good, thank you.
A new thing for both of us here.
I don't know about that. So can you tell us a little bit about yourself, about your background, and how you got into your profession?
Absolutely. I was born in England. I had surgery when I was 18 months old that required me to have physical therapy. So I went for physical therapy until I was about 13, and I really admired and, was grateful for everything they did for me. And that kind of stuck with me through, high school. And then when I decided to go to college, I thought that, this is the thing for me. So I studied in Manchester, England. And then from there, when I graduated, I worked in a hospital in Liverpool for 3 years. And then there was a shortage of therapists over here in America, and they were doing a lot of recruiting.
Oh, wow.
So I thought it'd be a good idea to come over here for a year. And 19 years later, I'm still here.
Wow. So you came down here, you didn't know anyone?
Didn't know anybody, got on the plane on my own. And
very neat.
Yeah. And when I first came over, I worked for Tenant Healthcare, and I worked at Durham Medical Center and Pinecrest Hospital. And did work in outpatients, intensive care units, did some work in the nursing homes, outpatients, and a little bit of home care as well. And as time went on, I kind of got a feel for, the area I really wanted to settle down in. And I decided to work in the home care section.
Oh, that's nice. When you like working with people, it's sometimes hard to narrow down what your specific calling is.
Very difficult. I love doing pediatrics, but once I had children of my own, it kind of was a little bit too heartfelt for me.
Okay.
And also having children, the home care, gave me the flexibility of making my own schedule.
Right.
And, just a better balance. So that's when I settled working with All County Home Care.
Very nice.
Yeah.
And you've been with them how long, did you say?
I have been with them for about 10 years now.
Okay, good.
Yeah.
So you're not going back to Liverpool anytime soon? You like it here?
No. After doing the socialized medicine and the private medicine, I'm thinking out of the two, this is the better way to go.
Well, good. I think everyone's lucky to have you here. So.
Well, thank you. And the thing, with the home care, the things I love, you get that one-on-one time with the patient. When you're doing outpatients, you're juggling patients. When you're in the hospital, your schedule is a lot more fast-paced.
Yeah.
Whereas the home care, you get the privilege of going into people's homes, seeing their home environment.
Right, more like personalization.
Yes,
That's
exactly.
Nice.
Listening to them, sitting and having the time to evaluate the whole situation that they are in. It's completely different when they're in the hospital and they're led in a bed that goes up and down and the head of the bed comes up. And
they may or may not want to deal with you.
Exactly.
Yeah.
But once they're home, reality sets in that this is it. And you get to see, do they have steps to get in and out of their house? Their bed isn't going up and down. How are you going to teach them to get on and off it safely?
Right.
Sometimes there's not somebody there to help them get dressed or prepare their meals, And if there isn't, how are you going to help them, solve that problem?
Makes sense. That sounds very rewarding.
It is. Yeah, it definitely is.
So can you tell us about how a patient might get on board with the physical therapist coming into the home? How would they go about that process?
Yeah, they have to get an order from a physician. Now, that could be if they were in the hospital, the doctor that's discharging them may order physical therapy for home if they deem them homebound. If they've been in a rehab facility, that physician that's discharging them could write the order, or it could be their primary care or a specialty physician, you know, if they've hurt their back, if they're finding that their balance is getting worse, any doctor can write an order for physical therapy in the home.
Okay, good. And as far as like coverage goes, that's more of a case-by-case type of thing, or?
Insurance-wise?
Yeah.
Well, with All County, we just see Medicare patients.
Okay.
Yeah, so, and it's billed under Medicare Part A.
Okay.
So
That works.
it reduces the complications of billing. But some home health companies do deal with private health insurance.
Mm-hmm.
And then, obviously, you know, it depends on what their policy is as to how many visits are authorized.
Gotcha. Very nice. So, what types of diagnoses do you typically see? I know you touched a little bit on that, but is it
it's a mixture. It's
Yeah.
a complete mixture. You know, a lot of the patients that I see are more orthopedic patients.
Mm-hmm.
It could be anything from a hip replacement, a knee replacement, which are often elective surgeries, and the patient's prepared for what date they're going into the hospital. You know, they already
Know what to
have everything
expect.
set up. Yeah, they have their raised toilet seat, they have their caregiver situation set up. But the majority of patients, you know, if you fall and break a hip, if you hurt your back, if you have an ankle fracture, if you have a stroke, things like that, you know, when you're walking into the patient's house, you have to help them deal with a very traumatic situation that was completely unexpected. But we see everything from, like I said, neurological disorders such as strokes, mini strokes, Parkinson's disease, MS. We see patients with pulmonary problems like COPD, CHF.
So I can imagine even being a physical therapist, you probably deal with counseling family members and that type of thing as well, right?
Very much so, yeah. Because you're walking into a situation, you never know what you're going to be walking into.
Right.
You know, as you're driving up to where they live, you're already kind of scoping out, okay, do they have stairs? Are they, you know, is their bedroom upstairs? How are they managing with this? And then once you get in there, you need to find out, okay, are you on your own here?
Mm-hmm.
You know, do you have anybody helping you? How much help do you need? And if they do have a caregiver, often the caregiver is completely frazzled, more so than the patient sometimes.
I bet.
Because they're overwhelmed with, oh my gosh, their loved one isn't feeling well, isn't doing well.
Mm-hmm.
Help me, help me, help me. Give me the reassurance that everything's, you know, going to be okay.
Right.
So as well as like the physical problems that you're dealing with the patient, there's a lot of emotional problems from the patient. And
yeah, you have to be there for that too. You have no choice.
Yeah, you do. You know, you have to go in with the positivity and the reassurance for them of, you know what, listen, this is usually as bad as it gets.
Right.
You know, when you first get home from the hospital, or you first get home from the rehab, or if you've just recently fallen and broken your ankle, or this is as bad as it gets. From here, we're going to keep moving forward. We never move forward as quick as the patient wants to.
Of course,
you know,
right.
they want to get well yesterday. So it's just constantly reminding them, hey, you're doing great. This is
Right.
the normal, you know, don't be disheartened. And it's easy for me to say because I'm not the one sat in their home 24 hours a day in pain or discomfort, you know. But it's just been almost like their cheerleader.
Yeah,
And saying,
that's
you know
wonderful.
what, we can do this, you know.
And you get to see that progress happen.
Oh, it's amazing.
So,
It
very
really
good.
is. It's very satisfying.
Now, how does the average therapy case proceed? Like, how long would you say it normally takes? And what's the process? Or is it hard to say? It's, I'm sure, very different per
It's
individual.
very different. It's very different for each, you know, patient, each diagnosis. You know, initially we get the order from the physician
Right.
with the diagnosis on it.
And do you work closely with the physician?
Absolutely.
Or, yeah.
Yeah. It's a whole team approach. You know, if ever I have a question about something, say, even today I had a lady with an ankle fracture and I wanted to know if she was allowed to put any weight on it. Call the doctor's office, you know, get the orders, we're good to go. Once we've got the order, we call the patient, typically the night before, schedule the appointment, explain who you are. Sometimes the patient's a little bit anxious. I'm not ready for therapy yet, you know, and
Right.
just reassuring them it's just the evaluation. I just want to come and see, you know, how you're doing, and we'll come up with a plan from there. So going in and doing the evaluation, and like I said before, looking at the living situation, you know, seeing how the pathways are. Do they have
What
throw
they have
rugs
to work
around?
with.
Yes. You know, are there little animals running around? Is there clutter around? You know, Do they have a walker? Do they need a walker? You know, do they need a raised toilet seat? Reassuring the caregivers, the family, you know, that, hey, I'm here to help, you know, this is what I'm going to do. And then evaluating the patient, obviously, talking with them, empathizing with them, evaluating, you know, their muscle strength, their range of motion, how they are able to transfer from a chair to standing, if they're able to walk, how they are managing to walk, are they able to bathe themselves, are they able to get in and out of the shower safely, can they dress themselves? And
so, like, what happens if you're in a tough situation and say there's somebody that is living alone? Have you been in that type of...
Oh, many times. Yeah. But that's, you know, when we have social workers available, we can send an aide in to help bathe them, you know, and calling family members and explaining the situation. But typically patients, especially ones that are discharged from hospitals or rehabs, the case managers in the hospitals make sure that, you know, the discharge is all set up and that the patient has some family support.
That's good.
Yeah. So.
Very good.
And then once you ascertain, you know, what the patient's inabilities are, then working with the patient as to what their goals are going to be. Because it's not just me coming up with the goals for the patient. You know, the patient, their prior level of function may have been just walking from, you know, their front door to their mailbox and back.
It may be different than what you expect for them.
Exactly.
Gotcha.
And if they said, you know, well, I never really walked further than 100 feet anyway, you know, as opposed to somebody that was out playing golf 3 days a week, you know. So then working with the patient as to realistic goals and what their expectations are and also what my expectations of them are. And then coming up with a treatment plan. Typically, we see the patients 2 times a week. With orthopedic patients, we more often than not see them 3 times a week initially, giving the patient homework, giving them their home exercise program to do because...
And how do you find they follow up with that homework generally?
It's completely an individual case by case. And typically you can tell the patients that have done their homework as opposed to the ones that have not done their homework. And it's explaining to them that, you know, if I'm coming twice a week for 45 minutes to an hour, those other 5 days of the week, you know, you have to do something for your own benefit.
Of course.
And it will help you get stronger. But, you know, it depends on the person. Some patients are a little less enthusiastic than others.
Some are probably too enthusiastic as well,
Some are too enthusiastic, and you have to slow them down and say, you know what, follow how many repetitions I tell you and do it how many times a day that's on your home exercise program. Because sometimes doing too much can be detrimental.
Of course.
You know, if it's an acute problem, you don't want to keep over-exercising that joint and making the inflammation worse, the pain worse. And of course, sometimes patients do that and they learn the hard way.
Right.
You know, so it is a case by case. But the patient is obviously the most important person in the whole plan. And also sharing with the caregivers, you know, this is what the patient, this is the homework I have given. Can you also help me out and make sure that these exercises are done?
Are happening.
Which sometimes they are and sometimes they aren't.
Yeah, there you give them a job too.
Absolutely. Yeah. And then after 30 days, we have to do a reassessment.
Okay.
And, you know, document to Medicare how the patient's doing. If the patient is progressing, if the patient has met their goals at that point, then we obviously discharge them. Some patients need a little bit more therapy.
What is the frequency of the therapy?
Typically like 2 times a week.
Okay.
You know, it depends on the diagnosis. It really does. You know, some patients, you know, if you get a basic arthroscopy of the knee and the patient, like I said, was golfing 3-4 days a week, they're probably going to heal pretty quickly and they may only need a few weeks of therapy, as opposed to somebody that's just had a major stroke and now is having difficulty even sitting on the edge of the bed and standing. Those ones you could be in there for, you know, a month or 2 until they're at a point when they're no longer homebound, and then you can pass them on to outpatient physical therapy if their doctor thinks it's going to be beneficial for them.
Gotcha. Is there like a specific cutoff as to whether or not they need your care as opposed to outpatient care, or?
When they're no longer homebound, you know, once a patient is telling me that, you know, I'm going out for lunch today and driving myself, and then I'm playing cards tomorrow and driving myself, and then I'm going and getting my hair done and driving myself,
Now, what do you do when a patient is maybe a little bit stubborn or their expectations supersede what you can provide them?
You have to, you've got to be diplomatic and tactful.
Of course.
And work with them. You don't want to
discourage.
No,
I'm sure.
exactly. You don't want to be like, hey, that's just not an option right now.
Right.
And you have to explain to them there is going to be a healing process, but, especially things like neurological problems, they do take a significant amount of time to improve, as opposed to, I don't know, an ankle sprain. That's typically, you got 6 weeks and you should be good to go.
Right. You're probably happy to deal with those cases, I'm guessing. You never know.
You don't know, to be honest, because sometimes...
Depends on the person.
It really does. Yeah. Sometimes patients surprise you.
Right.
Sometimes they progress a lot quicker, which is a wonderful thing.
Right.
And then...
That makes sense.
It sometimes works the other way as well, though, where you go in and you think, this is going to be a simple case.
Right.
And then you scratch the surface and you find out there's a lot more medically going on than the prescription that you had that just said back pain. And then when you walk in, you find out, they've got Parkinson's and they've got dementia and they've got diabetes.
And are you only able to work with what they prescribe you for? Okay.
Yeah. But I also have the ability to contact the doctor if I feel...
more is needed.
Yeah. Can I also work on, other aspect, say that they've got a pain in their shoulder that's really limiting them as well as their back. I can get those added onto the order. So, we don't, it doesn't have to be black and white.
Right. You don't have to feel guilty about not being able to help with something.
No. And I also, there's also the option of having, occupational therapists or speech therapists coming in. If the patient's had a stroke and they're having difficulty speaking or difficulty swallowing, you could order...
Someone on your team that
Absolutely. Yeah. And with the occupational therapy side, if a patient's having problems with dressing and cognitive problems, you could get the occupational therapist in to help as well.
Okay.
So there is, people often think that being in the home, you're very isolated.
Right.
It's like, oh my gosh, it must be so lonely. But the reality is you have a whole support team around you. And the beauty of having, modern technology with cell phones, there is always somebody at the end of the phone if ever, you have a question or if you need help. But it's also the challenge of, walking into the unknown with every patient every time.
Right.
Thinking, what am I going to find here?
It's got to be a challenge, but it's got to be exciting too, I'm sure.
It is. Yes, it absolutely is. Because I'm a true believer in it. To every problem, there is always a solution.
Right.
It might not always be the easiest solution, but there is a solution.
And are you ever hesitant, walking into unknown territory?
Yes.
Yeah. Always, maybe?
No.
You
but
feel
sometimes,
it out beforehand?
Yeah, sometimes, you do, unfortunately in this day and age, you have to be aware of your surroundings. And it does make me feel uncomfortable if I go into a patient's house and it's a male on their own and they lock the door behind me as soon as I walk in.
You think twice?
Well, yeah, it's human nature. You do think.
Of course.
Yeah. But I would say that happens very, very, very infrequently. Most people are so happy and welcoming that you're there to help them, and they bend over backwards to,
See, people doubt that sometimes, but we're all relatively good, right? I would say.
I would absolutely say that over 99% of my patients are wonderful. Yeah, they really, really are.
Now, do you have any idea? I'm sure it changes, but how many people do you see, say, a month or...
It completely changes.
Yeah,
it completely changes. When I first moved here 19 years ago, over summertime, we would be slow because so many snowbirds would go. Yeah. And over season, we were really, really busy. Now, more and more people are staying here all year round, and we are busy all the time. Yeah, so...
That's good, I guess.
It is.
It's good and bad, depending on how you look at it.
I know.
Right?
It's good job security. Yeah. But it's more on a daily basis of knowing, yesterday I saw 9 patients. It was a long day. Typically, I like to see about 6 or 7 patients a day.
Oh, wow. That's a lot, I'm sure.
It is. But, referrals come up and, sometimes it's hard to say no. And
so how long does your day last?
Yesterday it was 8 in the morning till around 6, 7 at night. But that's not my typical day.
Okay.
It's usually about 9 I like to be home by about 4 or 5.
Okay.
But then you've got all the documentation to do.
Right. So
After
there's still
that.
work to go.
There is. And plus you've got to schedule if you've got new patients, you know, schedule your new patients and print out all their face sheets and their you know, past medical history. And, you know, so you're prepared when you go in.
Yeah, but if you enjoy what you're doing, that's a good thing.
It really is a good thing.
Absolutely. All right. Well, it was wonderful talking with you.
Thank you so much.
Thank you so
It's
much.
my pleasure.
I'm glad you're going to stay with us and not go back to England, even though it gives you a beautiful accent.
No, I'm not going back anytime soon. But thank you.
Thank you.
All County Healthcare, Inc. is locally owned and operated, serving the Tri-County area, Palm Beach, Dade, and Broward counties for the last 25 years. The practice of medicine is changing dramatically. All County Healthcare, Inc. still does it the old-fashioned way, where our nurses and healthcare professionals come into your home to service your medical needs, providing you the fastest and best care possible. For more information, call 954-717-7027. And remember, Medicare Home Care is covered by Part A of Medicare with no out-of-pocket cost to you. It's your decision and only your decision on what healthcare agency you use. Call today. All County Home Health Care, Inc. at 954-717-7027. License 200999096.
Hi, I'm Deanna Barron, RN with All County Home Care. You know how I know that I've done a good job? We say goodbye. After you understand the medications you take, once you know that gaining 2 pounds in 1 day means you should call the doctor, when your wound is healed, when you can use your nebulizer all by yourself, when the goals that you and your all-county team of nurses, therapists, and aides established are met, we say goodbye. Very nice to meet you. But I hope I don't see you again, and I mean that in the nicest way possible.
You are listening to You and Your Doctor, Living Longer and Healthier, an informative show that helps you find answers to questions you always wanted to ask, but did not have that somebody that could make a difference in your life. Call into the show if you have a question at 888-565-1470, and we will put you on the air to inform all our listeners. Now, back to our show.
Hello, Megan again here with Dr. Baca.
How are you? Nice seeing you.
Nice seeing you as well. Now, Dr. Sean Baca is a rheumatologist who's been practicing in Palm Beach County since 1992. He's also a clinical researcher and volunteers his time as a clinical professor at FAU, Florida Atlantic University Medical School here in Boca Raton. He's president-elect of Palm Beach County Medical Society. He's going to discuss basically our current status of medicine, correct?
Yes, I'd like to talk about that.
Maybe
and
some.
Talk about the Medical Society today. So the Palm Beach County Medical Society has been around since 1919. And the way politics work in medicine is basically is that we all know about the AMA, but basically there are local level politics that occur as well. So you have the state level, which is a Florida Medical Association, and then each county has its own medical society.
Okay.
So we represent Palm Beach County. We're actually considered one of the best medical societies actually across the nation. What's interesting is our CEO, Tenna Wiles, is pretty well known anywhere. You know, I've gone with her to Washington recently at one of the AMA meetings, met with the president of the AMA, et cetera. And what's interesting is everybody seems to know Tenna was a state level, a national level, et cetera. Now, what the Medical Society does is we represent about 1,400 of the physicians that are practicing in Palm Beach County, a little over 2,000. So we have very good participation. In contrast to Dade County, which is 5,000 doctors, only 1,000 of those are actually members of the Dade County Association. So we have very high penetrance in terms of practicing physicians as being caring members.
Interesting.
Now, what we do is basically is we represent physicians on different aspects. One of them is things such as malpractice reform. You know, when that was going on, we tried to, basically let people know what was going on in terms of how it was hurting physicians and patients ultimately. We do a lot of things in terms of educating physicians because, as you know, things are changing very rapidly, especially in Medicare, so lots of rules and regs. And so we have seminars pretty much every month to go over the new computer things, the new ICD-10 codes, et cetera, et cetera. So, we try to keep people up with practice management. We also afford doctors who are in the program to get discounts on their malpractice insurance, also on the workers' comp, because as a physician, you're also an employer, so you have to have workers' comp and all kinds of other different licenses and insurances like everybody else, including discounts on health insurance.
Right, which is a big deal, I know.
Very big deal. So, besides doing those kinds of things, which are services to help make it easier for doctors to practice medicine, we go to Tallahassee, occasionally we go to Washington.
Okay.
We have one of our members is a recent president of the FMA, and as I'm going to be a county president starting in January of this year. And we go to the FMA, and what we do is we actually go to the annual meeting, and we actually pass resolutions that are basically very important that actually set the platform for the entire state in terms of their politics. One of the platforms that we passed last year was something about transparency. FMA, unfortunately, has a lot of good ideas that go fallow because nobody actually does anything with them after a while. And so we actually passed a rule, and this is actually one of my resolutions, that basically says that now every 6 months they actually have to give us a statement over every single thing that happens in the meeting, whether they passed, didn't pass, what they're doing about how much money they're spending, et cetera. And some of these resolutions are very important, such as, computer records. We've had a situation in our office where the company actually threatened to shred our data because we weren't willing to go to their more expensive. They're trying to keep upping, your fees and doing some other things that were pretty unethical. And so we actually transferred our data to another system, and basically it was very difficult to do. Actually, I had to hire an engineer to move all that data and all kinds of other stuff because things are not portable like people think they are. And they actually threatened to shred your data if you didn't pay them money for your own data.
Interesting.
That's actually illegal in Florida, and you have record rules that basically say that you're supposed to keep your records for at least a minimum of 7 years. And so these companies are not in Florida. They don't have to follow the Florida rules. And so we wanted to make sure that,
So if that got shredded, God forbid, you're in trouble, I would
right.
assume,
Well, your
right?
patients don't have the records. So this is a problem when records are in the cloud. And unfortunately, the federal government's kind of forcing you to put more and more stuff in the cloud. So, that's the downside to it, especially in a place like Florida. We have a hurricane-prone area. So we do a lot of stuff like that.
Okay.
We also have something called Palm Beach County Medical Services, which I think is very important, and the audience should really know about this. There's something called Project Access, which we've run for the last 10 years, which basically is free medical services to people in the county who do not have health insurance. And they've done some pretty amazing things. They've donated at least 10 million of free care in the last few years. And basically what they do is they line up doctors that are willing to see patients in their office for free. And then they try to get health partners such as physical therapy and also the hospitals. And if a patient needs an operation, for example, or something else, they try to get all the pieces in place so these people can get care. There was a patient who had breast cancer very recently who basically needed chemo and surgery, and they got all of that done for this patient without any payment. So, there are plenty of people that are willing to help. The problem is that the system is so weird that, people who want to help are basically hampered by lots of different things.
Right.
But you find that there are lots of good people everywhere. If you just get them together, good things happen. So they participate and they try to make these things happen. They integrate with the arthritis clinic. The Arthritis Foundation in Palm Beach County is a free clinic that I run in my office, and a few other large groups run in their office once a month for patients, again, who don't have insurance, who have bad arthritis and lupus and that kind of stuff. So they coordinate all that stuff and try to find a solution for everybody. So if you're a patient, you can call them. There's also on the website, they have all the emergency numbers that you might need, if you're a woman in distress, et cetera. So anything that you need in terms of services is usually on that website. So if you go to
good.
Palm Beach County,
I was going to ask you how we find those people.
Medical Society, and just Google their site, you can find a lot of useful information.
Okay, very good.
They also run HERC, which is the emergency medical portion. So they have coordinated with all the emergency rooms, because we had a crisis not too long ago of who's going to take care of patients when they have an true emergency, and the trauma network, because the problem was that whole thing was falling apart because it needed county support, because unfortunately there were very little funds to doing it, and a lot of hospitals were reluctant to take these patients. So they actually were able to cobble some deals, and they've been very helpful in terms of also coordinating some of this stuff, and then also the emergency management. So, for example, if we have a hurricane or we have some type of bioterrorism or some other things, they're actually coordinated with FEMA so that we can actually get people in place, in line, in case we have an emergency in the county. And again, anybody, any physician, and also people in the audience can participate in that if they want. They'll actually offer you free training. And of course, the physicians will do some of the more difficult stuff, but people may be used for even clerical stuff in a case of emergency. So those are also available. So if you call the County Medical Society, if you're willing to volunteer, they may have some nice things for you.
Good. And can we get into some of the features of Obamacare? What do you think would be maybe the better aspects of it? Or
well, as you know, most physicians and a lot of the public is not pleased with Obamacare because a lot of surprises. But the two things that are helpful is the issue about pre-existing conditions.
Mm-hmm.
For example, I have my friend Evan H. and he has horrible allergies, and basically he'd be concerned about being able to get health insurance when he gets a little bit older and out of college, because the problem is that you're going to be blocked with pre-existing conditions in the older policies.
Mm-hmm.
Also, people can be covered until they're 26 now. So a lot of tweeners, and you finish college, you're not quite sure what you're going to do, so you can still be covering your parents' policies.
Right.
Now, the problem is they didn't control the insurance companies enough, because insurance companies have many ways of getting you off the policies. And one of them is just basically in terms of prices. My daughter, Shauna, recently had mentioned that between her and her husband, who's hired by the city in St. Pete, that their premiums that the city pays is over $1,500 for just two people. And that's normal now. So, health insurance is now basically about the cost of, a mortgage.
Right.
And it's just insane, and people can't afford it. Now, the problem is that people think that, the doctors are getting this money. What the reality is doctors' salaries only constitute 5% of the entire U.S. health budget, 5% of the budget. So the problem is they attack the 5% and they forget about the 95%, and that's why we're in trouble right now.
Mm-hmm. And what do you think would be like the FDA's contribution to the upscale in pricing as far as drug prices and that type of thing?
Well, I think what's interesting is that a lot of people, have some very interesting thinking. We asked the federal government to basically fix this problem in healthcare, but people forget that the federal government is the reason that we have a problem in healthcare. Because years ago, you didn't have health insurance, you didn't have these things, and doctors took care of everybody. They went to people's houses. They would accept a chicken, maybe $5. If you could afford to pay more, they'd charge you more, and everything seemed to kind of work out. Now that you have all these people that are quote-unquote helping things, nothing's working out, because, now you have 20 bureaucrats for every one doctor. In the 1960s, you had 20 doctors for every one bureaucrat. So we're making it very bureaucratic, but we're not helping anything. So the FDA basically charges companies to look at their drugs. They actually insert themselves into the process and say, we think that you need to do the research this way. We need to think that these are your endpoints. We need to think that you need to do this way. And we're going to help you design your studies. Right now, it costs $1.2 billion to get a drug through the FDA. So people wonder why they have $400 pills. And then what you do is, after you get your drug finally developed, remember, not every drug makes it, so probably out of every 6 or 10 drugs, only one makes it. So it's a lot of money you're spending, okay, with no guarantees. Then you get it out to market, and then what will happen is that your insurance companies will basically won't pay for it for the first year, and then even Medicare won't cover drugs for the first 4 years, even though the FDA, the other part of the government, says we're covering it. It's approved. We think it's a good drug. The government won't pay for it on the other side. The VA won't cover it. And then finally they'll start using their drugs.
And why is that? They have to...
Well, it's cost containment. So they're trying to trying to prevent you from using the newer drugs when they can use the older drugs. Whether they're better or not, et cetera, should be up to the physician and the patient, not up to the federal government. Then what will happen is then after about 7 to 8 years, then you get to give the recipe away to China. And then they get to make all the money, put all your people out of business, and you start the whole process all over again.
Womp womp.
So you're killing competition. The way to have things cheaper is to have more options. I was the other day looking at my remote control on my television, so I was looking up on the internet to find the instructions, and there literally were 300 different brands of television on the market right now. And that's why televisions, these big screens, which get cheaper and cheaper every year, when I remember a 40 or 50-inch screen was like several thousands of dollars. You can buy it for about $200 now.
And you could get free channels back in the day, right? Not anymore.
Not anymore. Now all this stuff is much cheaper. And why is that? Because of competition. You should have 27 different versions of this drug. But the problem is that you create these mammoth companies basically in order to basically make drugs, and basically only few people can make them because very few people can pay the $1.2 billion to get it to market. Very few people are able to deal with the lawsuits and the negative press and the insurance companies, et cetera. So what you're doing is you're creating a system where they have to have these crazy prices because they don't get their prices. Half the time they give away the drugs for free, half the time this other stuff. So, nobody pays retail, just like nobody pays full price at a car dealership. And that's what people don't understand. If they say it's X dollars, the company expects only to get 50 cents on the dollar. And then what happens is that the insurance company is going to do all these other crazy things and to cut that price even more. So they raise their price not to get that price, but to get a lower price, because if they ask the price that they think they're going to get, they're not going to get that either. So it's a very crazy system. So, we have a lot of this other stuff, but, just the short patents by itself probably contribute to the high cost, not lower the cost, because if you have an annuity that's basically making money every year for the next 30 years, you don't need to raise the price. But if you know that you're going to have to give the recipe away to China in 7 years, give away all your intellectual information in 7 years, you're going to have to keep raising the price every year, because once that cookie's gone, it's gone. And when you think about it, Mickey Mouse is still protected under copyright rules, and he's almost 100 years old, and he's never saved one person's life, okay? And with alligators, maybe taking away one. So anyway, we have very schizophrenic about medicine. If you make money in any other business, you're a good guy. If you make money in medicine, you're a bad guy. And, I don't see that medicine shouldn't be the higher calling, and there's nothing wrong with a company making some money. But, we have big companies because little companies are basically pushed out of the race. And that's all because of the FDA, not because of any other reason. People love to complain, Pfizer's a bad company, blah, blah, blah. But the reality is you all have mutual funds. And what happens if Pfizer doesn't make any money? You'll be the first guy to dump them. So they're made to make money. They have to make money to survive. And if they don't make money, their mission is over. Only a private individual can do that, and you don't have that right now. And you're not going to do that unless you have small startup companies, but you can't do that if the FDA is charging you to do everything. And the FDA should be tax supported, which it's not, and it should actually help the smaller companies actually get drugs to market. And if you did that, then the costs would go down, and you probably have a lot of more inventive type of chemicals and other things to help people that might be cheaper and better, but you can't do that under the current system.
Gotcha. So what would you say about that recent story with the businessman that bought over a generic antibiotic company, was it?
Yeah, okay. The drug was called Daraprim.
Okay.
And it's an old drug, so a lot of people don't use it, but they use it for people who have HIV and they have some unusual infections, okay? So basically the bottom line is the price of the drug is relatively cheap, so this fellow bought this company and basically jacked up the price thousands and thousands of %, and got away with it. So everybody's vilifying this guy because he's a bad guy, obviously, because he's trying to make money. And again, if you were making money making bombs, that's okay. But if you're making money making drugs, that's not okay. So what happened is that everybody in the news and the press asked the wrong question. The question was, okay, this guy's a bad guy because he raised the price. No, the question is, how come there was only one company making this drug? How come there was no competition? And again, the answer is because it's very difficult. Obamacare just added 3% tax to gross on all these generic companies. Okay, that's their gross, not your net. The problem is that some of these companies work in 3 and 5% margins. It's very competitive. And so if it's very competitive, then how are you going to be able to compete when they just took away half your profit? So most of the small generic companies are going under right now as we speak.
Understandably.
Okay,
Yeah.
so the problem wasn't that this guy jacked the price up. The problem is, why are the market situations so bad that nobody wants to make this drug that's cheap?
That's the only person that can do it.
Right.
Yeah, I gotcha.
And so if your brother-in-law found, that nobody's making widgets and bought that widget company and doubled or tripled the price, everybody think he's a genius. But this guy was smart, maybe unethical, but that's not, for us to decide. If we had a competitive marketplace, the problem would never occur in the first place.
Exactly. Gotcha. Well, that makes sense. I also want to remind everyone that this is a call-in show, so if you have any questions for Dr. Baca, our number is 888-565-1470. But in the meantime, what about Medicare pricing? Do you think that is skyrocketed? Do you think it's reasonable? What are your thoughts there?
Well, I think most people don't understand Medicare.
Mm-hmm.
As far as physicians are concerned, physicians have not had a raise for Medicare in almost 15 years.
Mm-hmm.
So that's why you're seeing a lot of physicians going out of business. That's why you're seeing young doctors not going into private practice anymore, but want to be employed and work as shift workers. You're seeing a lot of doctors going concierge, where they're actually charging an extra fee on top of Medicare in order to pay their bills. So it's a misnomer. Medicare is paying less and less every single year, whether it's home health care companies or anything else. And part of the problem is of course, it's a good problem because we're getting more and more old people, which means we're surviving into older ages.
Gotcha.
And at the same time, we're not, taking care of, certain kinds of things with funding, et cetera, et cetera. But again, physician salaries are only 5% of the U.S. health budget.
Mm-hmm.
A lot of the money that goes to us, for example, we have a 70% overhead in our office. It's going to pay for the new EMRs and the computers and all the rules and regulations that occur in order for us to do our jobs, malpractice, et cetera, et cetera.
Right.
Years ago, you had one doctor, one nurse, maybe a receptionist. That was it. That took care of all your bills. And now, they usually have about 6 to 8 employees per physician in office, sometimes 10 employees per physician. Well, somebody's got to pay their bills.
Of course.
So that comes out of the overhead.
Mm-hmm.
And so, again, the overhead keeps going up. Fees are not going up. And so, there's an issue. Medicare's been doing some very crazy things lately. That one of them is very controversial right now is about drugs in the office.
Mm-hmm.
Physicians like oncologists and myself as rheumatologists give drugs in the office, and the markups are incredibly low. For example, if the drug is $1,000, we get maybe 6% extra for handling, but these drugs are very expensive.
So as in injectables, or you actually give out prescriptions
these are
through your
injectables.
office?
These
Okay.
are ones that have to be given by IVs, et cetera.
Okay.
We're not paid for the floor space. We're not paid for the rent and the space that's used dedicated for this other stuff. We're not paid for the tubing. We get one more fee for the nurse, and that's it.
Gotcha.
But we have to pay for these drugs out of our own pocket and hope that later on we get reimbursed. Now, of that 6%, usually we don't get that. Usually our handler, like our drug supplier, will get a certain couple of percentage off of that, et cetera. They're now talking about dropping that to 2% plus $16, which means a lot of practices will literally be underwater.
Wow.
Giving medication. So they have this crazy idea that doctors will use the older drugs because they're cheaper. The problem is if you're an oncologist, the older drugs are very dangerous and will kill you, and you have poor survival rates, and they just don't get it.
Mm-hmm.
Right now, there's a bunch of House, and this is bipartisan, members are both Republicans and Democrats are about to push a bill to Congress if this rule goes through, because the executive branch is pushing this without the consent of Congress. And again, this is something that's fundamentally changing Medicare. The 25 states are going to have this program, and nobody knows who the 25 states are. So right now there's a stay on it, but if it goes through, the oncologists have pretty much said, if you need chemo, just too bad, so sad, because you're just going to die because we're not going to be able to treat you.
That's sad.
Or people are going to have to go to very expensive venues, i.e. hospitals, which are allowed to charge twice the normal fees as Medicare Part B. Medicare Part A is allowed to charge twice for the same exact service. So if you want to lower costs, the worst thing that you can do is take the lowest cost providers, which are physicians, and basically push them out of the market.
Wow. And is that choice related which plan you're on, or what is the differential?
Well, plans are different. Now, Medicare, of course, is changed. Traditionally used to buy Medicare, which covers 80%, 20% people buy a secondary, and recently they started this drug policy. Traditionally, people will take Medicare, a traditional secondary, and a drug plan. It costs you usually between $300 and $500 a month, which again, as far as I'm concerned, is a bargain, considering that I'm paying about $1,000 a month with a $5,000 deductible. So I've got to pay somewhere in the order of, probably $15,000 to $20,000 a year before I get my first dollar back.
Right.
My health care. So I think they do okay with that. The good thing is that you can go to pretty much most facilities in all 50 states and you're taken care of. Then the most restrictive things are the HMOs, which basically say you can only go to this doctor, only this facility, and what they often do is they have high copays, so they get you on the back end. And then what's more popular for some people is the choice plans, which are actually kind of scary because if you have a drug that's very expensive, they may charge you a percentage of that to discourage you from doing it. I've actually seen people forego getting chemotherapy because they can't afford it. So if you pay a little extra up front, you're covered 100% for any illness.
Right.
But in the
Which you hope won't happen, but if God forbid it does, you've got coverage.
But that's what you need when you get older, because the question isn't when you're going to get sick. If you're going to get sick, it's when.
Right.
You know, and we don't know, and so that's why you're paying for insurance. But the problem is that, you know, sometimes they charge you 20 and 30% copay for each treatment. Wow. So a bag of chemo could cost you $10,000.
Oh my gosh.
So some people could have to pay $2,000 to $3,000 per week to get their treatments on some of these plans, you know, unless they have catastrophic, you know, waivers at the end. So this makes it unaffordable for some people, but the plans are designed to do that, to force you to go back to traditional Medicare when you get sick. So basically they keep you when you're healthy and they push you off when you're sick.
Wow.
And it's very well known that HMOs and actually these new plans actually cost the federal government more money than traditional Medicare. But because they pay twice, they pay when you're healthy, because the government gives them a check for $1,500 a month, whether you're sick or not, and they get to keep the money if you're not sick. And then the minute you get sick, they have nickel and dime you. Yeah. They nickel and dime you with all these copays. So you go, you know what's cheaper for me to pay the $500 a month? I'm going back to regular Medicare, and then they pay twice. So they pay when you're healthy, and then we pay you sick. So over a lifetime, people who jump back and forth actually cost the government more money. And that's the crazy part about it. And everybody knows, and, you know, the insurance companies get away with this.
Wow. So what about PBMs? Can you educate us on that a little bit? What is that?
Okay, now people talk about Medicare drugs not being negotiated. And the answer is they're very highly negotiated. Just the government's not doing it. And they're called pharmacy benefit managers, and that's PBMs.
Okay.
Okay, so Express Scripts is one of them. There are other companies. And these companies basically are making these huge profits. These companies didn't exist until a few years ago. One of them made over a $6 billion profit just last year. And when you think about them, they almost fit the definition of the Enron of medicines, because they don't produce drugs. They don't do anything except broker somebody else's drugs from somebody else's company to the insurance company. They're kind of an intermediary. And then what they do is then they will hopefully get the patient the drug. Now, they do some things that I think are very unethical, but they're getting away with it. And one of them is something called rebating. And what rebating is that the drug companies are actually told that they have to pay a fee to the insurance company, which can be tens of millions of dollars or even more, or they're not going to give the drug to any of their clients. So in other words, if you don't pay the rebate, none of our patients get it. And you have these things called tiers, tier 1, tier 2, tier 3. And apparently, depending on how much you pay, will determine what tier you're on. So a higher tier, you might be a preferred drug. So your drug may be equal to the other drug. Maybe the person's allergic to drug A, and they want to have drug B. Well, guess what? Too bad, so sad. Drug B is this tier, drug A is the higher tier, because the company of drug A was paying basically the money. The problem is that nobody knows where the rebate checks go. They're definitely not lowering people's premiums. They're definitely not going back to the patients. And what's happening is that these companies are making these excessive, huge profits because they're taking money. And again, what is a drug company going to have to do? Because they're businesses, they're going to have to raise their prices to make up for the rebate.
Exactly.
Now, if you were in Europe and I had an American company and you French company said, we will buy your product, but you need to pay us a check right now to do that. That's called a bribe. And the federal government actually puts you in deep trouble for doing this, because that's how Europe does business and used to for a long time. But if you do it in the United States and it's drugs, it's okay. You know why? Because the state governments, Medicaid, are now starting to ask for rebates. And so if the federal government's asking for a bribe and the state government's asking for a bribe, that's kind of makes the definition of making it legal, because everybody else is asking for one now. Therefore, it's okay to do it in the private sector.
The previous.
Right. So again, you're creating all these layers of bureaucracy, but basically there's no way that that's going to save money. You know, all you're doing is you're picking winners and losers and saying, well, we like this drug better, not because it's better, but because they write us a bigger check. And that's just unfair.
Where do you think these checks go? Do you know?
We have no idea, and that's really the question of transparency. You know, example is that there's something called visco supplements. Patients who have osteoarthritis of the knee, there are things that come from the rooster comb, which is this hyaluronate, which you can actually inject in people's knees. They're FDA-approved products, and there are several of them. commercial Blue Cross and Blue Shield very recently said, we're not going to cover it, period. The scuttlebutt is these companies refuse to pay the rebate. So therefore, they're not covering it. And Blue Cross made this crazy assumption that they decided the drug doesn't work. This is an FDA-approved product. The federal government says it works. There are studies that show that it works. Everybody says it works. My patients say it works. Blue Cross and Blue Shield decided it doesn't work. Why? The reason is they find some obscure reference. They'll go ahead and quote it, which is not the same thing as having FDA approval or not. That's the whole purpose of the FDA, is to approve a drug or not. They're bypassing that, and then they're basically doing that. But the real reason is because they're not giving them a decent enough, rebate. And again, the rebates are not the same thing as a discount, because the discount, everybody can see what it is. Maybe it goes to reducing your premium because they're paying less for your treatment, which would make more sense than writing a check that nobody knows where it goes to.
Gotcha. That's sad.
Well, but that's how medicine's being run now.
Well, that's too
Because,
bad.
a while
What are we
back,
going to do about it?
well, a while back, they said we want medicine run like a business, and now it is. It's cold and calculating. In healthcare, they say it's not personal anymore. And, as far as I'm concerned, when somebody has their hand up your Yahoo, that's as personal as it gets. So I think most people want their own doctors and they want their own situations, and you're not getting that nowadays.
It's too bad.
So as far as, other things, one thing that Medicare is doing now also is bundling payments. And that's also a very scary thing. And that's just started this year, and it's going to progressively get worse. One of the bundles that they're looking at is bundling orthopedic processes. So if you have a knee or hip replacement now and you go to the hospital's given all the money for the doctor, for the rehab, for the home health care, for everybody. And the hospital gets to keep it if they don't spend it. So what's happening is that if within 3 months anything happens to that patient that may remotely be related to the surgery, the hospital doesn't get paid again. For example, you have knee or hip surgery, and then 2 months later you have a pulmonary embolism. Well, now Medicare says the hospital's fault you had the pulmonary embolism, so the hospital gets to pay for the admission for pulmonary embolism. The patient has a heart attack within 3 months. They say, well, maybe it's a complication of that, therefore we're not going to pay for the heart attack.
Gotcha.
If you have an infection, they say, well, you know what, it's a complication of that, so we're not going to pay for that treatment. Okay, so what it's going to do is two things. It's going to allow the hospital way too much control. And what the hospital's going to be able to do is they're going to pick their own home health care. They're going to be able to pick, and what's happening now is people are not going to rehab anymore because they're just sending them right home if they can, because they don't want to pay for the rehab, and all this other stuff. And it sets some really crazy incentives, that basically, kind of cut people's care. And at the same time, you're going to have an issue where, people are going to potentially only pick patients who are healthy.
Then you're setting everyone up for failure a little bit in that regard.
Well, what you're going to do is you're going to take our sicker patients and say, you know what? It's going to cost us money because you might get sick. Let's not do your knee or hip surgery. They're about to roll this out now for heart failure, pneumonia, et cetera, et cetera. So next year, they're going to roll it out for more things. Okay. So basically, it's basically what they call capitation, which means you're HMOizing Medicare, even though people pay them good money not to be that.
Right.
So they're basically sticking in a situation where somebody's going to be able to call the shots, and that's what's scary.
And then to go back to Obamacare a little bit, I know it's been said that not a lot of people are renewing that Obamacare. Any thoughts on why that's happening?
Well, part of the problem is that one of the ideas is that patients should pay a lot of money out of pocket. That's actually one of their credos, is that we want patients to feel the pain. Because if they do, then what will happen is that they won't go to the doctor. But the problem is if they don't go to the doctor now, they might go to the doctor when they're sicker.
Right.
So the deductibles on these bronze plans are 40% of the entire bill. Plus they got a $5,000 copay. So if you take somebody with $20,000 income and ask them to pay $4,000 or $5,000 of deductible plus 40%, they can't afford that.
Gotcha.
So their insurance is not useful. So they really should have re-engineered so they're low copays and low deductibles. The poorer you are, and then as you go up in scale, maybe they can basically give you higher deductibles because you can possibly afford it, and that's not how it works.
So to end on a positive note, any last-minute positive solutions we might have to some of these issues happening?
Well, I think there are lots of solutions, but I think really what it's going to boil down to is we need decent competition. You need to allow companies to do their work. You need to let them have their intellectual material. You shouldn't give away patents after 7 or 10 years.
All right, well, good thoughts. Thank you so much for joining us.
Well, thank you for
Great
inviting me.
speaking with you. And thank you to All County Healthcare again for sponsoring the show.
Take care. Thanks.
Thank you for letting us share with you a longer and healthier lifestyle. If you have a doctor or are a doctor and wish to be on the show, call AMP2 TV at 866-244-5422, and we will put you on the air as soon as possible. Tune in next week for more information on living longer and having a healthier life. The opinions expressed on the preceding sponsored program were strictly those of its hosts, guests, and callers, and